Somewhere in the medical system there is a quiet but important disagreement, and most patients never know it is happening. On one side of it is the instinct that more information is better, that finding things early is always preferable to finding them late, and that a thorough investigation of the body's status at regular intervals is the foundation of preventive medicine and the responsible choice for an adult who takes their health seriously. On the other side of it is a growing body of evidence that in specific circumstances, in specific populations, and with specific tests, the act of looking, of finding, and of then responding to what is found produces a chain of events whose cumulative harm to the person being investigated exceeds the benefit that the original investigation was meant to deliver. This is not an argument against medicine or against medical testing. It is an argument for precision about when testing produces benefit and when, in the specific context of adults over 65, it produces harm that could have been avoided. The mechanism through which it produces harm is one of the most important and most under-discussed concepts in modern healthcare: the cascade effect, the sequence in which a finding from a routine test becomes a referral, which becomes another test, which becomes a biopsy, which becomes a procedure, which becomes a complication, none of which would have happened if the original finding had not been made in a person for whom the original finding would never have caused any clinical problem. I want to be very clear at the start of this video about what it is and what it is not. It is not a recommendation to refuse any specific medical test or to distrust your medical team. It is a framework for having more informed conversations about specific tests, understanding the specific evidence behind their benefits and harms in adults over 65, and bringing to those conversations the specific questions that turn a routine screening recommendation into a genuinely shared decision. Before anything else, what I share in this video is educational information only. It is not medical advice. Medical decisions should be made in partnership with your healthcare provider, who knows your complete clinical history. What I want to give you today is the specific knowledge that makes you a more informed partner in those decisions. I am Dr. Andrew Carter, and I have spent 15 years working exclusively with adults over 60. We addressed screening overdiagnosis and the cascade effect in an earlier video on this channel, where we covered PSA testing, mammography in older women, colonoscopy in low-risk older adults, cardiac stress testing in asymptomatic adults, and carotid ultrasound screening. In this video, I want to go further into the cascade mechanism itself and cover 5 additional scenarios, including full-body CT scanning, the comprehensive executive health panel, and the specific situations in which the harm is not from overdiagnosis of disease, but from the procedural complications and the anxiety of investigation. If this is your first time on this channel, subscribe right now because every week I bring you specific, grounded information about what your body needs after 60, and these 2 screening videos together give you the most complete framework I can provide for navigating medical testing after 65. Let me start with the cascade mechanism in its fullest form, because understanding it changes how every screening decision looks. A cascade begins with a finding. The finding is often real, meaning it represents a genuine anatomical or physiological variation that the test detected accurately. It is not a false positive in the traditional sense of an incorrect test result. It is a true positive for a finding whose clinical significance is uncertain, whose natural history in this specific person at this specific age is unclear, and whose detection has now created an obligation to investigate further. The obligation to investigate is not unreasonable. Medical practice cannot routinely identify findings and then advise ignoring them. The system is designed to follow findings with further investigation, because in some proportion of cases, the finding represents something serious that should be addressed. The problem is that in adults over 65, that proportion is often small, while the procedural risks of the investigations that follow are substantially higher than in younger adults. Adults over 65 have reduced physiological reserve in virtually every organ system. They metabolize anesthetic agents more slowly. Their renal function is reduced, making them more susceptible to contrast nephropathy from the iodinated contrast agents used in CT and angiography. Their bone mineral density is reduced, making them more susceptible to fractures from falls in hospital settings. Their immune function is impaired, making them more susceptible to hospital-acquired infections. And their cognitive function, even when apparently normal on office assessment, is more vulnerable to the post-operative cognitive dysfunction that complicates an estimated 20 to 30% of major surgeries in adults over 65. Post-operative cognitive dysfunction, a syndrome of impaired memory, attention, and executive function that can persist for weeks to months following surgery or significant procedural sedation, is not a minor inconvenience. In adults with any degree of preclinical cognitive vulnerability, including the amyloid burden that may be present in cognitively normal adults years before any clinical dementia symptoms, the inflammatory cascade and the physiological stress of surgery can accelerate the progression from preclinical to clinical cognitive impairment in a way that does not reverse when the surgical healing is complete. The person who entered a procedure cognitively normal may not exit the procedural cascade with the same cognitive baseline, particularly when the procedure was motivated by a finding that was never going to become a clinical problem. These age-related vulnerabilities mean that the cascade of tests and procedures that follows a finding from a screening test in a 70-year-old carries greater accumulated risk than the same cascade in a 50-year-old, while the benefit of detecting and treating the underlying finding may be smaller, because the natural history of the condition detected and the time required for any treatment to produce a survival benefit are both affected by the remaining life expectancy. This is the benefit-harm calculation that the cascade mechanism disrupts, and it disrupts it specifically in adults over 65, because that is where the benefit falls and the harm rises simultaneously. The first specific scenario I want to discuss is the full-body CT scan, which has become increasingly available through private health companies and direct-to-consumer screening programs marketed as comprehensive health checks for adults who want to know everything that might be wrong with their bodies. The full-body CT scan produces cross-sectional images of the entire torso, identifying anatomical structures in a level of detail that has no precedent in human health assessment. It finds things. It finds a great many things. And that is precisely the problem. A study published in Radiology examining the findings from full-body CT screenings in adults over 50 found that approximately 86% of participants had at least one incidental finding, meaning a finding that was not the reason the scan was obtained and whose clinical significance was uncertain. Of those findings, approximately 37% were classified as requiring follow-up investigation. Many of these were small adrenal nodules, small pulmonary nodules, renal cysts, hepatic lesions, enlarged lymph nodes, and aortic anomalies, the majority of which would never have caused any clinical problem in the person's lifetime. But once found, they require management. A small adrenal nodule identified on a full-body CT triggers a protocol of follow-up imaging, typically at 3, 6, 12, and 24 months, to assess for growth that might indicate an adrenocortical carcinoma, which in most cases it does not. A small pulmonary nodule triggers a follow-up protocol that may include additional CT imaging, at multiple intervals, potentially a PET scan, potentially a bronchoscopic biopsy, or a CT-guided biopsy. A renal cyst is stratified by a classification system into categories of suspicion that may require MRI, repeat CT, or urological referral. Each of these follow-up pathways generates radiation exposure, procedural risk, and anxiety. The radiation from a full-body CT is equivalent to approximately 2 to 3 years of natural background radiation, and in adults who undergo repeat follow-up imaging, the cumulative radiation dose from the original scan and its follow-ups becomes a carcinogenic exposure in its own right. The CT scan ordered to find cancer is generating the radiation that modestly increases cancer risk in the person being scanned. The United States Preventive Services Task Force, which reviews screening evidence systematically, does not recommend full-body CT scanning for any asymptomatic indication. The American College of Radiology, similarly, does not support its use for routine screening. Both bodies note that the harm from incidental findings, the cascade of follow-up, the radiation exposure, and the procedural risk outweighs any demonstrated benefit in asymptomatic adults. Type in the comments right now if you have had a full-body CT scan and what findings it produced that required follow-up, because the real-world experience of the people watching this video is one of the best illustrations of the cascade mechanism that I can share. The second scenario is the comprehensive executive health check, the full-day assessment offered by private health providers that includes extensive blood panels, multiple imaging studies, cardiac screening, and specialist consultations for a substantial fee. These programs are marketed specifically to adults over 60 as the ultimate preventive investment, and they attract patients who are health-conscious, financially secure, and understandably motivated to know as much as possible about their health status. The problem with the executive health check is not any individual component. It is the aggregation of multiple tests in a single person, without a formal assessment of the prior probability of disease for any specific test, and the resulting statistical certainty that some findings will emerge from the combination, even in a perfectly healthy individual. When 10 tests each with a specificity of 95%, meaning a 5% false positive rate, are performed simultaneously in the same person, the probability that at least one will return a false positive result is approximately 40%. 10 tests with a 5% false positive rate each produce a 1 in 2.5 chance of at least one finding that is not real. Add the real incidental findings that tests produce in older adults whose anatomical variations are genuinely more numerous than in younger adults, and a comprehensive health check in an adult over 65 is almost certain to produce at least one finding that requires further investigation, whether or not any of those findings represents actual disease. A study published in the British Medical Journal, examining the health outcomes of comprehensive health checks in adults over 60, found that the checks produced more investigations and more diagnoses, but did not produce improvements in cardiovascular mortality, cancer mortality, or all-cause mortality, compared to standard care over 10-year follow-up periods. The additional diagnoses generated by comprehensive health checks were associated with additional treatment and anxiety, but the treatments did not translate into the improved survival outcomes that the screening was intended to produce. This does not mean that all health check investigations are without value. Targeted, evidence-based screening for specific conditions with demonstrated screening benefit, including colorectal cancer screening in appropriate age groups, blood pressure monitoring, HbA1c and lipid assessment, and breast cancer screening in appropriate age groups and health contexts, produces benefit that justifies their inclusion. The problem is the untargeted comprehensive approach that adds tests beyond these evidence-based ones, in the hope that comprehensiveness will capture something important that the targeted approach misses. And share this video right now with one person in your life over 65 who is considering or has had a comprehensive health check and has never been told about the statistical certainty of incidental findings and the cascade they generate. That specific piece of information changes how those programs are evaluated. And if you are not yet subscribed to this channel, tap that button now and ring the bell. I want to tell you about Linda, 69 years old, retired solicitor from Manchester, England. She had undergone a comprehensive private health check as a gift from her family on her retirement. The check was thorough. It found 3 things requiring follow-up: a 7mm adrenal nodule, a 5mm pulmonary nodule, and a borderline elevated CA-125, the ovarian cancer marker that is included in some comprehensive female health panels. Each finding triggered its own cascade. The adrenal nodule required repeat CT at 3 months, 6 months, and 12 months, all of which showed no growth. The pulmonary nodule required a low-dose CT at 6 months and a PET scan at 12 months, neither of which showed features of malignancy. The CA-125 required gynecological referral, pelvic ultrasound, and a 3-month repeat blood test. All findings resolved to no clinical significance. Linda spent 18 months in investigation. She described the period as one of the most anxious of her life. She deferred a planned trip to Australia with her grandchildren, because she felt she should not travel until the nodule investigations were complete. She had 2 CT scans in addition to the original, adding approximately 4 years of cumulative radiation dose. She had a PET scan. She had 3 gynecological appointments. At the end of 18 months, she was cleared of all concerns. Her health was exactly as it had been before the executive health check. But the 18 months were not. She told me, "I thought the check would give me peace of mind." I told her, "What it gave you was a series of findings that needed to be investigated, because that is what findings require." The question that was not asked before the check was whether the findings it was likely to produce were ones for which the investigation pathway would produce a better outcome for you than not knowing. The third scenario concerns a specific aspect of comprehensive cardiac screening that extends beyond the stress testing we discussed in our first screening video: the use of cardiac CT coronary calcium scoring and CT coronary angiography in asymptomatic adults over 65. Coronary artery calcium scoring, which uses CT to quantify the calcified plaque burden in the coronary arteries, and produces the Agatston score that many people will have heard of, has a legitimate place in the risk stratification of intermediate risk adults in their 50s and early 60s, where it can refine the decision about whether statin therapy is appropriate. In this context, it is a reasonable and well-supported tool. The problem arises when coronary calcium scoring is performed in adults over 65, who already have established cardiovascular risk factors, and who are already on appropriate treatment for those factors. In these adults, the calcium score is almost certain to be elevated, because coronary calcium accumulates with age and with years of cardiovascular risk factor exposure. A high Agatston score in a 70-year-old with 10 years of hypertension on treatment is not an unexpected finding that changes management. It is an expected anatomical finding that confirms what the clinical risk profile already established. But once obtained, the high score often triggers anxiety, further investigation, and discussion of more aggressive intervention that was not indicated by the clinical risk profile alone. CT coronary angiography in asymptomatic adults, which visualizes the soft plaque of the coronary arteries alongside the calcium, finds non-obstructive plaque in the majority of adults over 65 because non-obstructive coronary plaque is essentially universal in this age group. Finding it leads to discussion of intervention, and the intervention for coronary artery disease in asymptomatic adults, particularly stenting of non-obstructive lesions, has not been shown in randomized trials to reduce the rate of heart attack or death compared to optimal medical therapy, a finding that the ischemia trial, published in 2020 in the New England Journal of Medicine, established definitively for stable coronary disease. The stent that follows the CT angiogram in an asymptomatic 70-year-old does not reduce the risk of a subsequent heart attack. It does carry a small risk of procedural complications, including the very heart attack it was intended to prevent, access site bleeding, stroke, and kidney injury from contrast agent. The investigation found something real. The treatment of the finding produced harm without benefit. If you are not yet subscribed to this channel, tap that subscribe button now and ring the bell, because the distinction between finding something real and knowing what to do with what you find is one of the most clinically important distinctions in modern medicine, and it is one that this channel is specifically designed to help you navigate. The fourth scenario addresses a finding that is extraordinarily common in adults over 65, and that, when discovered through screening, generates a disproportionate amount of subsequent investigation and treatment: thyroid nodules. The thyroid gland contains nodules in the majority of adults over 60, when examined with the sensitivity of modern ultrasound. Autopsy studies have found thyroid nodules in approximately 50 to 65% of adults. The prevalence of clinically significant thyroid cancer in the same population is approximately 2 to 3%. The difference between the prevalence of nodules and the prevalence of thyroid cancer is a large pool of benign nodules that, when found incidentally through neck imaging performed for other reasons, or through thyroid ultrasound included in comprehensive health panels, triggers the guideline-driven evaluation pathway of biopsy and follow-up. Fine needle aspiration biopsy of thyroid nodules, while generally a safe procedure, produces an indeterminate result in approximately 20 to 30% of biopsies. An indeterminate result, meaning the biopsy cannot definitively confirm benign versus malignant, creates a further decision point at which many clinicians and many patients, now anxious from the uncertainty, opt for surgical thyroid lobectomy. The thyroid lobectomy removes the indeterminate nodule definitively. It also removes half of the functioning thyroid gland, and if pathology returns benign, as it does in the majority of indeterminate cases, the patient has undergone surgery and may require lifelong thyroid hormone supplementation for a nodule that would never have caused them any problem. The rate at which thyroid cancer was diagnosed in the United States increased by approximately 300% between 1975 and 2009, largely driven by the incidental detection of small papillary thyroid cancers through neck imaging performed for other reasons. The rate at which adults died from thyroid cancer did not change over the same period. The additional diagnoses and treatments produced by increased detection did not save additional lives, while the complications of the surgeries and the lifetime thyroid hormone management produced real harm to people whose incidental nodule would never have become a problem. The American Thyroid Association guidelines now recommend against ultrasound screening for thyroid nodules in asymptomatic adults, and against fine needle aspiration of thyroid nodules below specific size and sonographic risk thresholds. These guidelines represent the professional consensus that the harm from detection exceeds the benefit in the majority of incidentally found thyroid nodules in adults over 65. The fifth scenario concerns a specific diagnostic modality that is increasingly available and increasingly included in comprehensive health assessments, whole genome or broad panel genetic testing marketed as health risk assessment. Direct-to-consumer genetic testing, which reports variants associated with risk for specific diseases including Alzheimer's disease, Parkinson's disease, hereditary cancers, and cardiovascular conditions, can provide genuinely useful information in specific clinical contexts. Knowing that you carry the BRCA1 or BRCA2 variant for hereditary breast and ovarian cancer, or the Lynch syndrome variants for hereditary colorectal cancer, has real management implications in adults with relevant family histories, and in the appropriate age groups for those implications. The harm scenario arises specifically with APOE4, the strongest known genetic risk factor for Alzheimer's disease, when it is reported through a direct-to-consumer testing panel to an adult over 65 who did not specifically seek this information and who has not received genetic counseling before or after the result. Approximately 25% of the general population carries one copy of APOE4, which increases lifetime Alzheimer's risk from approximately 10 to 20%, and approximately 2 to 3% carry two copies, which increases lifetime risk to approximately 50%. An adult who discovers their APOE4 status through a consumer genetic test and receives no genetic counseling is left with a risk probability and no framework for what to do with it. The anxiety this produces is well documented. Studies of adults who receive APOE4 results show significantly elevated anxiety, depression, and health-related worry in the period following the result, without the corresponding uptake of the lifestyle changes that would most meaningfully modify the Alzheimer's risk that the APOE4 variant represents. The information generates distress but not productive action, because the context for understanding and responding to it was not established before the result was received. This is not an argument against genetic testing in appropriate clinical context with appropriate counseling. It is an argument that receiving risk information outside of a clinical framework with counseling support produces harm in the form of psychological distress and impaired quality of life that the information was intended to prevent through early risk awareness. Here is the framework for applying everything I have described to your specific situation. Before agreeing to any investigation beyond the evidence-based screening tests that have demonstrated mortality benefit in your specific age group and health status, ask two specific questions. The first, what is the probability that this test will find a significant finding in my specific risk profile? And what proportion of findings at my age are likely to be incidental and benign rather than clinically significant? The second, if a finding is made, what is the standard investigation pathway that follows, and what are the procedural risks of that pathway in adults of my age and health status? These two questions, asked specifically, require the person answering them to provide a benefit-harm analysis rather than a simple recommendation, and a benefit-harm analysis that is honest about the incidental finding rate in adults over 65, and about the procedural risks of the cascade that follows, will produce a more considered recommendation than the default recommendation of thorough investigation. The goal of medical care after 65 is not simply the detection of abnormalities. It is the preservation of the function, independence, cognition, and quality of life that determine how the years ahead are lived. Some investigations serve that goal. Others, in specific circumstances, work against it by generating cascades of investigation and treatment, whose cumulative harm to function and quality of life exceeds any benefit from the findings they produced. The distinction between these two categories is not always obvious, and making it well requires the kind of informed, specific, questioning engagement with medical recommendations that this video has been designed to support. The specific language that most effectively prompts this conversation at a medical appointment is, before I agree to this investigation, can you tell me what proportion of findings in adults my age and health status require follow-up investigation, and what the typical cascade looks like from a positive finding in terms of procedures and their associated risks? This is not an adversarial question. It is an informed consent question. The information it requests is information your doctor should be able to provide, and if they cannot, asking for a referral to someone who can is entirely appropriate. In the United Kingdom, patients can ask for a benefits and burdens discussion for any investigation before consenting. In most countries, informed consent for investigations requires disclosure of material risks, and a doctor who cannot discuss the cascade risk of a comprehensive investigation is not meeting that standard. 4 things to carry away. First, the cascade mechanism in which a finding from a routine test generates a sequence of further tests and procedures whose cumulative harm may exceed the benefit of the original test, is most pronounced in adults over 65, whose physiological reserve is reduced, whose procedural risk is elevated, and whose remaining life expectancy reduces the benefit timeline for treatments initiated in response to findings. Second, full-body CT scanning and comprehensive executive health panels are associated with near certainty of incidental findings in adults over 65, and the investigation pathways those findings trigger produce real radiation exposure, procedural risk, and psychological harm in adults whose incidental findings would in most cases never have caused clinical problems. Neither the U.S. Preventive Services Task Force nor the American College of Radiology recommends these as screening tools in asymptomatic adults. Third, thyroid nodule incidentalomas represent one of the clearest examples of detection without benefit, with the tripling of thyroid cancer diagnosis in the United States, producing no reduction in thyroid cancer mortality while generating substantial harm from surgery and lifelong thyroid replacement in adults whose nodules would never have been a problem. Fourth, the goal of medical care after 65 is quality and function, not simply the maximization of detection. A healthcare conversation that begins with "what findings am I looking for?" is different from one that begins with "what outcomes matter most to this person," and which investigations are most likely to produce those outcomes, rather than to undermine them. You have the right to ask for the second type of conversation. Share this video with one person in your life over 65 who is considering a comprehensive health check or a full-body scan, and who would benefit from understanding the specific cascade mechanism before making that decision. And subscribe to this channel, because every week I come here with one purpose: to give you the specific information that makes your medical decisions genuinely informed rather than reflexively compliant. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.